Hey everyone, let's jump right into this explainer. Today, we're tracing the exact clinical pathway of depressive disorders. Because in clinical practice, major depressive disorder isn't just a simple low mood. It's a highly specific, pervasive, and systemic illness that requires rigorous diagnostic criteria and targeted management. So let's look straight at that pathway.
So when does ordinary sadness cross the line into a clinical diagnosis? Well, to answer that, we have to look really closely at the exact diagnostic threshold separating everyday mood fluctuations from a true medical condition. You see, ordinary sadness fluctuates, but clinical depression, it's pervasive. It often features diurnal variation, meaning the patient's mood is predictably worse in the morning, and it strikes right at the core of human biology, altering sleep, appetite, and motor function. All right, the magic number here is 5. A patient actually has to exhibit at least 5 out of 9 specific symptoms nearly every single day for 2 straight weeks to meet the criteria for a major depressive episode. Now, at least one of those symptoms must be either a deeply depressed mood or anhedonia, which is a total loss of interest or pleasure. The remaining symptoms make up this incredibly heavy physiological and cognitive burden. We're talking significant weight changes, insomnia or hypersomnia, observable psychomotor agitation or retardation, severe fatigue, inappropriate guilt, and inability to concentrate, and suicidal ideation.
Now, this breaks down exactly how we diagnose chronicity. Notice how persistent depressive disorder, you probably know it as dysthymia, requires a massive 2-year duration, even if the daily symptom count is lower, say requiring low mood plus just 2 additional symptoms like poor appetite or low energy. It's literally that sheer, unrelenting marathon of low mood that defines it. That's a stark contrast to the severe, acute 2-week crash we see in MDD.
Moving on to Section 1, ruling out other conditions.
Before we lock in a definitive psychiatric diagnosis, we absolutely must establish a differential diagnosis to rule out medical or neurological mimics. But honestly, the trickiest differential, it's normal human grief. It is so crucial to distinguish clinical markers from normal bereavement. Grief is a completely natural process. But look at severe clinical signs like mummification, where a patient is literally immobilized by their mood. When you combine that with active suicidal ideation, severe guilt of commission, or psychotic delusions, you are no longer dealing with simple grief, you are actively managing a major depressive episode.
Okay, let's get into Section 2, clinical variants and linked scenarios.
Depression definitely doesn't look the same in everyone, right? So let's track a few linked clinical scenarios to see how diagnosis and management actually adapt in the real world. Imagine patient case A sitting in your clinic presenting purely with unexplained physical aches. They might have chronic back pain, headaches, or digestive issues. But if you ask them about their mood, they absolutely deny any feelings of sadness. They insist their only problem is physical.
The core mood change is totally hidden behind these somatic complaints. But if we dig just a bit deeper into their sleep architecture, their energy levels, and their appetite, the criteria for a major depressive episode start checking off, even without that subjective complaint of sadness.
We diagnose this as masked depression. The physical symptoms are quite literally the mask. Management here requires a super delicate hand. It typically starts with first-line SSRIs, like escitalopram or sertraline, accompanied by psychotherapy. This dual approach helps alleviate the physical manifestations while simultaneously uncovering and treating the psychological root.
Okay, let's pivot to patient case B. Their symptoms act like absolute clockwork. Every single year, as the days get shorter and the winter months set in, their mood just crashes. But they don't just get sad. Their presentation changes in a very specific metabolic way. They present with this very specific, almost metabolic triad. First up, high irritability. Second, and I find this fascinating, an intense craving for carbohydrates, like breads, pastas, and sweets. And third, hypersomnia. They are sleeping excessively, but never actually feeling rested.
This is seasonal depression. And what's really cool here is the direct, targeted management. Rather than immediately jumping to standard antidepressants, this specific variant responds beautifully to light therapy. You literally expose the patient to a 10,000 lux light box, which, just to put it into perspective, is roughly 20 times brighter than normal indoor lighting. They do this for 30 minutes every single morning. It resets their circadian rhythms and directly manages that depressive triad.
Now, let's take a look at patient case C. This scenario is strictly defined by its critical timing, a patient exhibiting profound depressive symptoms right before or just after childbirth. Now, this isn't the standard baby blues, which usually fade quickly. We're talking about a severe, pervasive mood drop accompanied by exhaustion, anxiety, and sometimes intrusive thoughts.
The absolutely crucial diagnostic window here is pregnancy itself, stretching up to exactly 4 weeks postpartum. When it comes to this diagnosis, timing is quite literally everything.
We categorize this as peripartum depression, and managing this, it requires careful, immediate intervention to ensure the safety and well-being of both the mother and the child. Because of the risk to the newborn and the extreme stress of the postpartum period, a rapid combination of safe pharmacotherapy and vital social support has to be initiated immediately.
Finally, picture patient case D. This patient's mood actually brightens slightly if something good happens. Say they get a promotion at work or a good friend visits. They have mood reactivity, which might actually trick you into thinking they aren't clinically depressed. Yet they feel physically weighed down and are constantly overeating and oversleeping.
Look at these two bizarre physiological symptoms standing out here. First is extreme rejection sensitivity, where perceived slights are just utterly devastating to them. The second is leaden paralysis, which is this sensation where the patient's arms and legs literally feel like they're made of lead. These are massive clinical clues.
Despite the name atypical, this is actually a highly specific, well-documented clinical variant called atypical depression. It really requires astute diagnostic skills to spot it, mostly because that mood reactivity can easily fool untrained observers into thinking the patient is totally fine.
All right, Section 3, Tackling Treatment-Resistant Cases.
So, what actually happens when first-line interventions, like SSRIs and therapy, just fail? Well, the clinical escalation pathway is strictly mapped out. First, and this is absolutely critical, you check patient compliance. I mean, are they actually taking the meds? If yes, and there's some improvement, you increase the dose. Zero improvement, you switch the medication entirely to something like an SNRI or mirtazapine. If that fails, step 3 is augmenting the antidepressant with an atypical antipsychotic. Finally, if the depression remains completely unyielding, we deploy the heavy hitters, adding lithium, T3-thyroxine, or even newer interventions like esketamine nasal sprays that are specifically approved for treatment-resistant depression.
But sometimes we just don't have the luxury of time to slowly step through an algorithm. We're faced with scenarios so severe, like a patient who is entirely mute, locked in a catatonic stupor, utterly refusing to eat or drink, or suffering from intense mood-congruent psychotic delusions. In these acute, life-threatening moments, those standard oral medication pathways are bypassed entirely.
These extreme presentations are the absolute indications for immediate hospitalization and electroconvulsive therapy, or ECT. While ECT sometimes carries this outdated pop culture stigma, clinically speaking, it is a highly effective, rapid, and totally necessary intervention for these life-threatening scenarios. It works when nothing else does, and it works fast.
Now, we escalate to those extreme levels of care because the stakes are just incredibly high. Literally 15% of patients with major depressive disorder commit suicide, and those risk factors skyrocket if they've made a serious prior attempt, are older than 45, struggle with alcohol dependence, or have a history of violent behavior. We aren't just treating sadness here, we are actively trying to save lives. I want to leave you with this stark reality drawn directly from the clinical data. 80% of patients will experience further episodes. This demands years of long-term maintenance just to hold the darkness at bay. It really forces us to ask a difficult question. Should we fundamentally stop treating clinical depression as a temporary infection that we just cure, and instead start managing it as a lifelong systemic condition? Let that sink in as you process these clinical pathways. Thanks for hanging out with me on this explainer, and keep learning.